Good morning, everyone, and welcome to the Dr. Mahesh Raju Annual Lecture in Medical Education. Dr. Raju is a medical internist here in St. John since 1990 and a valuable asset to our medical education community, formally since 2006, but I suspect a lifelong teacher and a lifelong learner. He has constructed and organized multiple learner programs, both for undergraduate and postgraduate studies, and was one of the founding fathers of our very own Dalhousie Medicine, New Brunswick. He has been granted many awards and accolades: the Sir William Osler Award, a national award for excellence in medical education, clinical practice, and professional development by the Canadian Society of Internal Medicine at their annual meeting in Halifax. This is a very prestigious award given to only 2 internists in the country a year. The Canadian Society of Internal Medicine bestowed on him a named national award, the Dr. Mahesh K. Raju Award for Best Resident Mentor. This is awarded yearly in his name. He is a St. John resident and DMNB famous, but more importantly, a friend to us all and a mentor by which we are grateful now and for years to come. Welcome to our annual lecture.
Good morning, everyone, and welcome to the Mahesh K. Raju lecture. And I'd really like to thank Dr. Sarah Gander and Samantha Gray for putting on this wonderful program. Normally, we would have a guest lecturer to be present here today, but due to COVID, the organizers have decided to do a new format, and hopefully it'll be a lot of fun exchanging ideas and talking about various things.
Dr. Raju, you've mentioned in many other talks, including your Osler lecture, the influence of Hippocrates and what he has had on your life as a doctor. We all know the adage, first do no harm. Tell us about the idea to celebrate the opening of Dalhousie Medicine, New Brunswick with a statue of Hippocrates.
Well, we had just assigned a building to host the medical school, and we were busy planning and getting things ready. And at that same time, I unfortunately was undergoing a heart surgery. The morning of the heart surgery, I was feeling quite forlorn and worried and concerned, a bit depressed. And so as I walked into my bathroom to have a morning shave, I was struck by a sudden moment of inspiration. I thought to myself, what can I do to make the opening of the medical school a memorable event? Something unique, something relevant, something that most people would enjoy. So I thought about doing a statue of Hippocrates, father of modern medicine. I happened to have a good friend, a fellow colleague, Dr. John Tedeschi, who works out of New Jersey. He's a renowned internist, a renowned sculptor, and I called him up that very morning and I said, John, can you do something for me? He said, yes. I said, could you do a bust of Hippocrates that we can put on display at the front entrance of the medical school? The reaction I got from him was astonishing. He became emotional, he started to stammer, and he finally said, you want me to do a medical school, for a medical school, the statue of Hippocrates? I said, yes. He goes, oh, Mahesh, what an honor. I would love to do it, he said. And 8 months later, it was ready and brought to Boston from New Jersey. I drove down to Boston to pick up the statue, and I was flabbergasted by the absolute wonder of the bust of Hippocrates. As I came through the customs and immigration, I was concerned about the potential duties and fines and what have you. And so I put on a brave face, drove up to the counter, and he goes, "Anything to declare?" I said, well, I countered by saying, "Have you heard about the new medical school in St. John?" He goes, yeah, I heard about it. That's great. New Brunswick is getting a medical school. I said, yes. And what I have in the back of my car is a statue to be placed in the medical school for everybody to see. Matter of fact, the next time we're in St. John, I invite you to come up and have a look at it. He goes, "You're kidding." I said, yeah, it's right there. He looked at me. He said, "Go on." He just passed me through. He didn't bother looking at it. There was no there was no duty or fines or anything like that. And that was quite something. So we managed to get the statue to the medical school, set it up in time for the opening the next day.
Dr. Raju, tell us what it meant to you to receive the Sir Osler Award and the importance of bedside clinical skills. One can't help but wonder if with all of our virtual visits now, could we be missing something?
In 2009, I was honored to present the Royal College of Physicians and Surgeons of Canada and the Canadian Society of Internal Medicine to present Sir William Osler Lecture. I would count this as one of the highlights of my career. It was such a pleasure to have internists from right across the country, and afterwards we discussed the principles of Dr. Osler's clinical method and how it was imperative for all of us collectively to enhance the bedside clinical skills, which, with the onslaught of new technology, have been slightly eroded. So we talked about a particular study by one Dr. Peterson, who had he had 80 internal medicine patients, and he referred them to 4 general internists. Each internist had to assign a diagnosis after each aspect of the clinical method. So after the history, they wrote a diagnosis. They wrote a second diagnosis after history and physical, and a third diagnosis after history, physical, and preliminary lab tests. Turns out, history predicted 61 out of 80 patients. 61. History and physical combined, 70 out of the 80 patients were given the right diagnosis. If you add the lab tests, it made up the other 9%. So the importance of that is that history and physical made the diagnosis in 71 out of the 80 patients. But yet, in modern medicine, we spend all the time in the lab with x-rays and ultrasounds and all that, but the yield is much less. So it's very important to maintain clinical skills that would point you in the right direction and more often than not provide the right diagnosis. Thank you.
One thing I really took from your lecture was Dennis Diderot's three principles as sage advice for all of us, especially our students, in how to maintain observation as a powerful tool in medicine. Tell us more.
Denis Diderot, an 18th century French philosopher, stated that there were three principal ways of collecting knowledge. Number one, observation of nature. Number two, reflection. Number three, experimentation. He went on to state that observation of nature must be diligent, reflection profound, and experimentation exact. What a wonderful mantra for modern clinical medicine.
We are learning more and more about our virtual opportunities for patients and for diagnostics. These technologies improve our everyday. What would you describe as the power of our own observation in the interactions with our patients, and how we should be careful not to let technology take over?
Are we moving too far along technology and not spending enough time on the clinical method? Yes, there's every danger of that happening, and but we do need technology to confirm exactly where the tumor is, and so whether it's surgically resectable or not. So it plays a vital role in our diagnostic method. But the ideal situation is to use technology along with the judgment and insight of a thoughtful physician and a useful patient-physician interaction. So it's not all technology. You have to put that in place with the other humanistic aspects that makes it worthwhile to proceed along a particular clinical path. Just to reiterate to my students, observation is perhaps the most important towards making a proper diagnosis. How does a patient look? How do they react to a particular situation? What's the patient's body's physiological response to things happening within his body and around him? And what is the state of mind of the patient? Is he depressed? Is he aggressive? Is he withdrawn? These are all important factors beyond making the immediate diagnosis to be considered when embarking on a particular clinical course.
Can you give us an example from your own career?
First day surgical rotation in medical school in South India. All the students were huddled around the surgeon, around the bed of a young patient who was having episodes of severe abdominal pain. These episodes would last 10-15 seconds, and the patient would be in total agony, arching his back, clutching onto his stomach, and following the painful episode, he would be covered with a lather of sweat. What was curious to me as a medical student was between these spasmodic episodes of pain, the patient appeared to be quite stable and largely normal. So the surgeon noted jaundice, passed his hand on the patient's abdomen, and said it was free of peritonitis. So that was an unusual combination with a normal abdomen, severe abdominal pain. So he asked me to do a stool examination to see if there was any evidence of ova, cysts, or parasites that could be infected in his abdomen. So he looked under the microscope when we prepared the slide and followed it up with, this patient needs an OR, go to the OR. So I went along, made the arrangements to the OR. I was puzzled as to the combination of the episodic abdominal pain, the jaundice, and the benign abdomen, and yet the surgeon wanted to go to the OR. So I went to the OR after hours to observe what would happen, and to my astonishment, he pulled out a live roundworm from his common bile duct. So, unbelievable. And as he retrieved the worm, it wrapped itself around the forceps. So that singular episode of observation, reflection, put me on a magical mystery tour of clinical medicine for a long time. So going back, looking at the case, he deduced that this young boy had episodic pain, but no evidence of rupture of an organ, as there was no peritonitis. The patient had jaundice. He had pretty quiet periods of time in between these episodes of pain. And what he found in the examination of his stool, that the patient had cysts, ova, and parasites in the stool. So he deduced from that that the patient, in fact, had a pathology in the common bile duct which produced the jaundice, severe abdominal pain, and that's why he went to the OR and found a roundworm in his common bile duct. So that is the power of observation. The next story is an example of observational and reflective skills par excellence. An 18th century surgeon working in London, England, was examining a patient at the hospital surrounded by his trainees. A little while later, the maitre d' of the ward tapped him on the shoulder and stated that the gentleman there across the room has been waiting his consultation for the past 2 hours. So John Hunter looked up at the patient from 30 feet away, observed him for a few seconds, and went back to the task at hand. Over the next few minutes, he kept looking up and observing the patient. And when he was done as to what he was doing, he asked his students to turn around and observe that patient from across the room and to venture a diagnosis. He was met with blank stares. So John Hunter went on to say, that man there is suffering from liver disease, mainly the right lobe of the liver, and these incredulous students asked, how did you make a diagnosis from 30 feet away? Elementary, my dear students. That man there has lost weight, jacket 2 sizes too big for him, his belt is pulled in, the light from the window reveals that he's jaundiced. And did you notice, my dear students, he said, he has his right elbow tucked below his right ribs, splinting every painful breath. I can only deduce from this, Sir John went on, that that man there is a servant to Her Majesty's Royal Navy, serving the far reaches of Egypt or India, and has come home for medical treatment.
History can tell us so much, as you've illustrated, Dr. Raju, from the examples, both relatively current and even from further away in time. I think we've learned today that the power of observation and reflection can actually even far outweigh what our diagnostics can do, and the importance of keeping clinical skills as part of our assessment of patients. What a great lesson for us as the ones who worked with you and came after you, and the students who will come after us. Thanks everyone for listening to the Dr. Raju Medical Education Lecture today, and we'll move on to a live Q&A on your Zoom call, so stay tuned.
I don't know if anybody has any comments or wanted to ask any questions or has any sage advice for us as well. We have a good spread of lots of experience across the Zoom call today.
Sarah, it's John Steves here. Mahesh, I was always told that a physician didn't really become a real physician until he'd been a patient. And I know you had some interactions with the healthcare system. I wonder how those interactions have affected your understanding of clinical medicine and how it should be practiced.
Well, speaking from personal experience, it depends who you're dealing with. If it's a surgeon or non-surgical person, the people doing surgery, they go right to the chase. There's no quarter given to this or that or any different type of situations. They tell you, you show up at this time, this place, and then that appointed time you're wheeled off to the OR. You don't see the surgeon, but maybe I'd see them 2 weeks before. And then the surgery is done. You get 1 or 2 visits, post-op, and then the third day you're out. So it's really cut and dry. It's driven by economics, pressures of work, excessive patients. So it's different in the non-surgical fields. We tend to engage the patient a little more. We tend to explore the patient's experience with the disease, their hopes and aspirations, concerns and worries, and we tend to try to answer, what'll happen to me, doc? Can I go back to work? Or will there be this or that? And all the concerns, we try to address those. And we don't have a scalpel as a tool, but we do somehow try to find the time to explore more about the patient. So it's like treating the patient who has the disease rather than just treating the disease. So it's a more comprehensive and a holistic approach. And that's what drove me to internal medicine in the first place.
From a surgical perspective, I was always intrigued with the observation made to me that surgeons, after a relatively short interaction, have to convince the patient that they should put their life in the surgeon's hands. And as a consequence, I always told the students to very carefully look at the interaction between the surgeon and the patient to see how they accomplish that in such a short space of time, if they're really going to be an effective surgeon. The other piece that always struck me about the clinical exam was the hands-on aspect of clinical examination seemed to be linked to patient compliance with management. And the impressive ones were, I remember one patient who told me that ever since I examined her knee, she's been pain-free. And that just gives you the understanding of how much importance the patients place on the actual contact with their physician. Thank you.
And sometimes you get unexpected pearls that you don't plan for. It just happens. I remember one particular case. I was doing my GI procedural list, and I got a phone call stating that there's a patient so-and-so ward that needs consultation. So I asked 3 or 4 questions before I hung up. I said, tell me about the patient, what are the symptoms? And I was told that she's from Portugal, she's Canadian, but she had gone home, Portugal, visit family, and she's been sick as a dog since leaving Portugal, and she's been vomiting straight for about 8-9 days. She can't keep anything down, she's dehydrated. And so she was subjected to probably 6 consultations with my subspecialty colleagues, and every diagnostic test for each subspecialty was carried out. She had endoscopy, she had ultrasounds, she had everything possible. And then I get the call as a general internist. So I said, okay. So I asked one of the questions. I had a list to attend to. And then once I got those answers, I called my student at the time. I said, there's a patient, so-and-so ward, so-and-so room. I'd like to go and examine that patient and write a full detailed history and physical. But before you do that, I said, go to the library and read up everything you can get your hands on Cushing's disease, a rare condition. And somehow that struck me with the initial conversation with the medical staff at the ward. So she went to the library, read up about Cushing's disease, and then she went and saw the patient. But half an hour, 45 minutes later, I got an excited phone call from her. Dr. Raju, the patient has Cushing's disease. And she was beside herself because she's never, well, it's a rare disease to make. And when you do make it, it's so rewarding because you have an instant cure and we can keep them healthy for the rest of their lives. In fact, I still see that patient nowadays when I go to the grocery store occasionally, and she recalls that whole story all over again. So sometimes that gut feeling, sometimes, take 1 or 2 isolated clues, and it's like John Hunter diagnosing hepatic liver abscess from very varied clues, such as suntan in February and all that. So, that makes medicine a lot of fun. It's not so clinical, it's more than that. You get to live with the patients, with their disease, and share with them some of their experiences. Wonderful experience.
Dr. Raju, I think Todd Lambert has a question.
Hey, Todd.
Hey, Mahesh. Always good to see you.
Oh, good to see you.
I just was wondering what you think over the years has led to this erosion. What do you think are the major things that led to the erosion of us being confident in our history and physical, making diagnosis instead of using all these extra investigations and over-investigation before we can kind of have that confidence? And I guess onto that was, do you think things like choosing wisely and initiatives like that are going to help us get back to relying more on our clinical skills?
Well, since 1978, the time we spent at bedside teaching has dropped from 71% to 16%. So that takes away a huge opportunity for learning. So I would always encourage teachers and to engage students. And in the end, it comes down to a triad. You have the patient, you have the student or learner, and you have you, the tutor. And it's a triad. And all three people involved in that triad, including the patient, have to be active participants in bedside teaching. So the patient should be encouraged to interact, should be encouraged to ask questions, interrupt if you have any concerns, and encourage to give us more details about what they were feeling, what their symptoms were like. And so the patients have an equal opportunity to participate in the triad to help come to a diagnosis. As far as the students are wonderful. They're fresh, they're enthusiastic, they're eager to learn, they follow instructions, they do the best they can. But watching the physician-patient interaction just a few feet away, they learn a lot by just being there. They learn about patient-physician interaction, they learn about communication skills, professionalism, and empathy, and those are very valuable lessons. This is where tutors have to play a big role in role modeling, encourage the students to participate, as well as the patients to participate to get the maximum of his bedside involvement. Totally agree with that. What was the second part of your question? I forgot.
I was just wondering if you think things like the Choosing Wisely initiative and those types of ways to get us to rely more on our clinical skills and less on investigations or treating it appropriately are going to be helpful.
Yeah, I mean, technology made things so easy. Spend 15 minutes with the patient at the bedside, but in the current day, they would have gone down, got the CT, the ultrasound, and back within 10 minutes. So it's much easier to use that as a fallback position, but it misses something in the translation. I think essentially it is a physician-doctor or physician-patient relationship. It's almost sacrosanct, and you have to really address the major concerns. And what are they worried about? Oh my God, am I going to make my mortgage payments? Can I go back to work? What's going to happen to my kids? Will I lose my house? So you have to take all that into consideration as you approach the patient, do the right thing, but not worry them unduly, but at the same time be absolutely truthful with them. So as William Osler said, a good physician treats the disease, a great physician treats the patient with the disease. And there's a subtle difference, because making a diagnosis and giving some pills is not the end of the answer. You have to follow through and be there for them.
The times that I've given lectures and explored some of the literature around how we are teaching the next generations and millennials talks a lot about how busy everybody is now and how we actually positively reinforce efficiency and quickness, and that we'd be doing well by our students to actually start to model and teach them more time for contemplation and thinking and reflecting on the patients.
Yeah, absolutely. I think we overload our workload. Gives a little time for what we were just talking about. I think we don't have to work that hard. I don't know what the real motivation is. People have different motivations, but you can make a handsome living working at a reasonable pace, paying attention to your patients, your students, residents, and your family and yourself, and enjoy it all the better. I think part of the consequence of what we're doing currently is essentially burnout. And people have this horrible feeling inside of them as they walk towards the hospital that, oh my God, we'll have to do that all over again. It doesn't have to be that. But people make it so put undue pressure on themselves for reasons that I fail to understand.
One of the number one causes of burnout is feeling like you're working really hard but not making a difference. And wouldn't you agree, Mahesh, that when you make those patient encounters and actually feel like you understand your patient and make a difference in their lives, that's, well, curing cancer is nice. People want us to do that, but we want to make them feel better. But at the same time, I think the difference that we make in their lives is what sustains us too. And I think it can be done with technology. I did a whole virtual clinic yesterday, and I made a breakthrough with a teenage patient that I've been trying to crack her for years. And it wasn't until yesterday because we hung out in her bedroom, right? It felt like I was her friend sitting on the end of her bed, I know. And so I really got a glimmer into her life. And by the end of it, we were cracking jokes. And so sometimes there's an intimacy that technology still allows. That's a new frontier, I don't typically go and see my teenage patients on the end of their bed, so in their house.
Well, I can't tell you the number of times these are patients I have forgotten. I remember the case, but I don't remember the names or anything. Meet them at the grocery store, at Imperial Theater, or in the city market. You're just walking around minding your own business, and there's a tap on your shoulder. And the first thing I'm going to do is to give you a big hug. Okay, and then they proceed to tell what happened and who they were and what happened to them at the time and the care that they received. So that is extremely gratifying. That's the reason I always felt I could get up in the morning and try to do my best.
Any other comments or questions from folks?
I think we talked a lot about the physician and patient. I also wonder if the expectations of patients are changing over the years because of technology as well. So I also find with the, things that they want done quickly, obviously happens in my field quite often, it's never fast enough, but also of just wanting everything. They're always asking for tests because I think the perception out there, because of what we've done over the years, is that that's the answer. And sometimes I feel like they're getting frustrated when I'm not going right there and I'm actually spending more time asking them questions, and they want me to order the test because that's going to be the be all end all, and trying to explain to them that oftentimes they know or I know before the CAT scan shows what they're worried about. So I guess my question with technology is, are we I think as medical professionals we're kind of catching up to where people have been wanting to do all this virtually, but I also find there's this expectation from patients that technology solves a lot in medicine, and I think perhaps that's a false expectation.
Yes, I know. Well, over the years, we have increasing reliance on technology, of course, and I think it's getting better and better and better. They can pick up things. You can't fault that, and you have to rely on that technology. But before we get there, a thoughtful patient-physician interaction, talk about all the manifestations found in those technologies. What does it all mean, and what does it mean to the patient's future? So I think the patients don't understand technology, but they're worried about it when they're under the CT or MRI. I know I had an MRI more than once, and you're lying there on the stretcher 45 minutes. You can't move a muscle, you can't even blink, because the old magnetic thing is flipping around your head. And the kind of thoughts that go through you in those 45 minutes when you're really quite alone, and you see your family, you see how is this going to change your life and what could or could not have depending on what they find. And I don't think us physicians pay enough attention to that, the innermost concerns and worries of the patient. They may make light of it, they may try to soft pedal it, they may, whatever reason, but it's real. Because when you're given a diagnosis that you got this, and in my case happened to be a brain tumor, my thoughts immediately went to the worst scenario. There was no in between. I said, oh my God, what's going to happen? And you get into a deep funk here in the cave, going around in the dark. I wonder if physicians, at least in the cancer department, you could tell me whether they pay enough attention to those innermost fears and concerns and worries. Enough concern. Hopefully the social workers will pitch in and do all that. But in the end, regardless of all that, you feel alone. You feel the world is against you. Why me? Think of all the things you could have done better, treated people around you better, be kinder to people. And your mind just goes off on a tangent, and it's all very emotional. So I think doctors have to pay attention to that. So if the patient expresses some concerns, you may not have the answers, but an open and frank discussion would be very helpful.
Thanks for sharing that.
I mean, I think that's something we like to model for our students. And sometimes I wonder if they think we're, not teaching enough science or medical terms, but often when I have learners with me, when they're spending time in an oncology clinic, I want them to know the patient's stories. I want them to know how, this patient is actually still taking care of his grandkids and, was still on treatment for X cancer. And I want them to get to know the patients because you're right, it could happen to anyone and you want to be there for them. So but sometimes I wonder if the students think, oh, Dr. Grace just let me go in and talk to patients and I'm not really learning any oncology.
Yeah, and I love talking to veterans. We're getting fewer and fewer of those folks. But one, he's better, he's on the way to recovery. I like to explore some of those experiences that he had way back when World War II. And the amount of clarity and emotion that comes out. And as I recall some of the stories of the buddies and family and what have you, wow, you can't write a novel like that. It's really potent, emotionally.
Mahesh, I think that Richard Goldblum captured that very nicely with his mantra that the primary role of physicians is to relieve patient anxiety. When you think of all that you do, regardless of the concrete things that may relieve the anxiety, it's sometimes helpful to think of that as we go about our business.
Absolutely, because you are the patient's advocate. He doesn't have anybody else to turn to. You have his history and his investigations in hand, and he turns to you for whatever he's worried about. And you have to recognize that responsibility and that you are there for the patient and you'll do everything you can to help them through that experience. And again, that's what makes the difference.
I think it's always been nice that the CanMed's roles really outline the different roles that we have as a physician, and that medical expert is only one of those, and the rest are so profound in their professionalism. And of course, there's the scholarship, but then also the advocate. And that's certainly a big part of pediatric life, especially in St. John and in New Brunswick. So I hear that loud and clear. And it is sometimes feels, doesn't it, Sam, that like our students, when I have them looking up a 5-kilometer radius of food banks for a patient, and they didn't think that was going to be part of their job, but the social terms of health are so important. And I think as people who participate in curriculum development and the rollout of courses in the university, we should just, continue to be mindful of these things. So we make it more overt. And, Sam, if that's part of your assessment of a student and their ability to communicate and their professionalism, then maybe they'll be in our position years from now and reflect and thank us for making them go and talk to people.
Can you hear me?
Yeah, Paul, it's great.
Yeah, great. That's great, Sarah and Sam, and great to see you, Mahesh.
Hi, Paul.
I really enjoyed those stories. I enjoyed working with you. I've enjoyed hanging out with you and so on and so forth. And it's great to see you amidst all this COVID craziness. A little bit of sanity there, maybe, for us. Maybe could you just reflect on our internal medicine residency program? Just some comments about that. You were there at the start of that, development of the hospitalist program, the dovetailing of the two. We've had residents now come back that we trained to come on staff as internists and other specialists, and just some of your comments and thoughts would be great, Mahesh.
Well, it was a team effort. I have to give a lot of credit to Dr. John Dornan. We all know how John Dornan operates. He gets things done, maybe not the most conventional of ways. So our first year when we opened up to 2 spots in internal medicine, we did not get any takers because that was our first year. So nobody was interested in coming here. So what does John do? He drove to Halifax and he looked at all the residents who were accepted there, and he talked a husband and wife team to leave Halifax and come to St. John. And it was a big coup, really. I mean, otherwise we had everything set up, but nobody applied. And here was John, convinced his 2 young people to join us. And that proved to be the beginning of the success of internal medicine. There were brilliant residents from, I think, Saskatoon someplace. They're both subspecialists now, practicing. And when the word got around that these 2 brilliant residents were presenting in national conferences and regional conferences, and that's how we got a start. And next year, we had no trouble filling our spots, and it's been wonderful ever since. So that is probably, give all the credit to John for making that happen. And the advantage we had in St. John, which people at the time did not realize, was that we had a terrific internal medicine focus. So we had a strong internal medicine team, and with very close cooperation with the subspecialists, who in fact rotated on the CT we developed. And so the resident could be, 1 week could be working with the nephrologist, the week after with the endocrinologist, the week after that with general medicine. So they had a wide variety of experiences, and with the hands-on training and the lot of freedom to express themselves and to dwell into things, and incredible. I mean, we used to tell the residents, when they worked under me, I insisted that each time the patient had a procedure, whether it be a biopsy of something or bone marrow or EKG, echo, doesn't matter what, CT scan, I insisted to the resident to go down and review the CT scans firsthand with the radiologist, go to the pathologist, review the slides, and that's what they did. And when they came back, they had already looked at all the things we have done firsthand, and they felt a lot more confident that they were able to understand the case a lot better. So being a smaller place, large amount of population, patients, incredible facilities, it afforded us the luxury to expand and to explore different ways of teaching. Another trick I used to use is you had a patient come in with pneumonia. So I would instruct the residents not to look at the x-rays. And I said, I want you to tell me where the pneumonia is by your respiratory examination. And so next thing you know, they're cussing and palpating and listening. It's amazing how quickly they caught on. And they said, yeah, this one's dull. That's not, they start to see the difference. And just a game, really, but it taught them something, that you can rely on your fingers, your ears, to come up with a reasonable idea.
So, Sam, I think one of the take-home messages Mahesh is offering us is that we need to break the rules and be innovative to push things forward in med-ed. So get ready for that.
The sky's the limit, because in a place like St. John, it's wide open. The limitation is you. and no limitation with students or patients or resources. Is how much energy do you have to make use of all these opportunities?
Fantastic. Anybody else want to say any words or have any questions for Dr. Raju or myself?
Hi, everybody. I'm Mahesh.
Hey, Tony.
Congratulations to Sarah on this lectureship, and appreciate the way you use the platform, very deferential and consistent with your podcast. Mahesh, I'll give you two questions, and you can spend more time on the one you find more interesting. So one is, you mentioned that you've been a patient, and I suspect you spent a chunk of your career as a clinician and medical educator before you, the same level of experience as a patient, and then perhaps the latter phase of your career spent some time having been a patient. And I wonder how that experience influences your advice about, or your perspective on how medical education should be delivered, having spent so much time as an educator and then some time as a patient. The other question I had was just to turn the title of the session and look forward and say, you've always been a great voice for not losing what is good about clinical medicine in your teaching and in our teaching students. And I wonder if you could just give a perspective over your career on how advances in medicine might have influenced the delivery of medical education, and how you would say medical education needs to be different now than it used to be, or do you think it fundamentally doesn't need to be different? So you can pick what you want to talk about there.
Well, I'll tell you, being a patient after decades of practice was quite a change in perspective. No longer I could be in charge of anything or do any orders. I just sat there waiting for the next order. But it was perhaps the most profound experience in my life. When you go from a position of strength, full professor of medicine, dean, and all the accolades, I guess, to go from those heights to be reduced to, wearing a Johnny shirt and sitting in a dark room, it's alien to me. I mean, the room wasn't alien, but that situation was terribly alien. And but what choices one have? I was quite worried about my family, my wife, parents. They were still alive then, and I wondered, why me? Why did this thing befall me? And there's no answer to that. And so you have no choice but to shrug your shoulders and say, okay, I got to deal with what's ahead of me. And so the first time I looked at my own MRI, I was astonished. There was massive cerebral edema, and it just obscured the whole brain. And a cold chill sort of went down my spine when I saw that. I said, oh God, can this be the end? I thought. And the experience as a patient is extremely humbling. It reduces you to your lowest common denominator. You're helpless. You look for answers. You pray. You curse. You swear. And then the chemo started. The radiation started. And that itself was a treat, having radiotherapies 8 o'clock in the morning for 6 weeks or something, and your brain being zapped by all kinds of x-rays, and you wonder what's left. I mean, okay, if I get through the cancer, what would I have left? Then I thought, well, let's just get through the cancer. We'll worry about what's left later. So, it was very profound. It shakes you to the core. It makes you realize what most important in life. Your family, your wife, kids, parents, brothers, sisters. And, you just take that experience and you hopefully turn it into positive, and as you get better, and in this case, I did get better. And I'm ever so thankful that I was able to get to treatment minutes from my home without any worry about cost or money or anything like that. And I was fortunate enough that the girls in the radiotherapy department made sure I had the first appointment in the morning. So I would come in first thing in the morning, get it done, and leave before the next patient showed up. And just that little bit of privacy meant a lot to me. And so I was always the strong one, helping people, and I didn't want to be seen in that light. So it's a game changer. It dispels any notions about life or afterlife or anything, any philosophy you may or may not have. It changes all of that. And it seems like, at least in my case, I had to start anew. I had to rebuild myself, rebuild my personality, my outlook on life. And so it was a new beginning. So that helped. And the second question was?
Mahesh, just before we move on to the second question, I can't help but try to tie this to how we can be good models for our medical students. I mean, somebody had the good grace and sense to afford you that privacy and to advocate for you when you were feeling your most vulnerable. Maybe to Tony's second question, which talks about the future and how we can continue to do business, but maybe a bit differently. How do we maintain some of these other roles? Our students will get their medical expertise, but will they get the advocacy and the professionalism and the kindness that we need them to have when they're not seeing patients as often or seeing them in this venue? Hopefully that does justice to your question, Tony.
Yeah, I think too often as physicians, patient comes in, we make a diagnosis, do some tests, confirm, do a biopsy, and prescribe treatment. And that's where it ends. But there's a lot more than that, because the patient is looking for you, looking at you, to help you through their journey. He wants to hold on to somebody's hand as he walks through his recovery. He needs to feel like he's a human being who has a problem, and it's up to physicians to develop that relationship, to let them know that they're not alone, let them know that we care for them, and do everything you can to alleviate pain and suffering, and if there's hope to give plenty of it, because when you're down and out, you're looking for anything to hold on to. Any word, any hug, any handshake, all those little things matter. And I know family doctors are more prone to do that because they see the patient over time, but doesn't stop internists or anybody else for that matter to develop that special understanding with the patient and walk that journey together. Because you are the primary physician. And if he can't count on you to answer his questions or talk about his deepest feelings and emotion, then something is lost in the translation.
I can't help but say the point that you said this morning in our discussion after this lecture, which was maybe we're too busy. I mean, Sam, you made this point too, that, sometimes students look at us like, why are we chatting so much, or why are we having them go in and just get to know patients? But the importance of taking the time and not just filling our days with as much as possible so we do have the time. I thought that was a really nice take home from this morning.
Yeah, I think most of us have control over our practice. You don't have to be driven by, for whatever reason, whatever the motivation is. You can't just go from 8 to 5 and just work, go home. I think it's more important to enjoy the medicine, enjoy the patient, enjoy seeing people recover and become healthy again. The joy of medicine. I think with all the stress of schedules and patients, we lose the fact that we are privileged people. Society looks to us for their salvation. And it's a shame not to use that opportunity and to help things along in a little better way.
Well, can't think of a better time than now to take that inspiring message away with all of us. A lot of demands being asked of all of us right now, particularly with the COVID situation. And so I thank you so much for your wisdom and inspiration. And I think it's been a really nice time to just gather, if you will, but be together and maybe not talking about COVID and talking about how important it is to recognize the difference that we all make in our patients' lives and each other's lives and our students' lives.
Don't ever underestimate that.
Yeah.
Don't ever underestimate that.
So true. If anybody has any burning parting words, you're welcome. We have about 2 minutes left. Otherwise, we'll again say thank you, and thank you for the honor of being part of this lectureship this year. It's always a pleasure, Dr. Raju and Sam.
Well, thank you so much. You and Samantha doing a great job. I've enjoyed this tremendously. It got me out of my cave and out again. And it's been very enjoyable. Thank you so much. Thank you for everybody for joining in.
And everybody check out the Fact Dev Lounge podcast on iTunes or wherever you get your podcast. This will be there if you want to reflect back with some notes in the show notes about some references to things that Mahesh spoke about or I spoke about, and check out the other episodes. And stay safe and have a wonderful rest of the fall and holidays.
Thank you. Thank you, Sarah.
There's lots of comments on the chat there. Everyone singing your accolades and really appreciated your hour that you spent with everybody. So I think everyone left inspired, and thank you so much again.
Thank you so much.